So welcome. This is Sammy Saab, a hepatologist at UCLA, doing this webcast on the best practices on ongoing monitoring patients with MASH. MASH has become a major public health and medical concern in the United States. As you all know, 25 to 30% of the U.S. population and across the globe have MASLD, has some degree of hepatic steatosis in the setting of the metabolic syndrome. Now, as hepatologists, we have a very myopic view of this. We look at MASLD as a stepping stone to MASH and cirrhosis and liver cancer, appropriate so, because MASH has emerged as a leading indication for liver transplantation, as a leading risk factor of liver cancer, and as a common cause of cirrhosis. As you know, MASH is really the extreme form of MASLD, in the sense that MASH is a form of MASLD that's associated with severe liver injury, namely fibrosis. And that places people at risk for cancer, cirrhosis, liver failure. So our focus today is looking at MASH. Now, historically, when we saw someone with fatty liver disease, we relied on liver enzymes to identify those who are at high risk of having MASH and do a liver biopsy for confirmation. But with the emergence of MASLD being so prevalent in the United States and across the globe, there's been a movement away from doing liver biopsies. At the same time, understanding that liver enzymes are a very poor surrogate marker of liver injury. So if you look at guidelines across the globe, whether you practice in the United States, Europe, and South America, and Asia, all guidelines have as an entry point for risk assessment of people with MASLD to see who may have advanced fibrosis is a FIB-4. And that's calculated using simple parameters of AST, AOT, platelet count, and age. And it projects the likelihood of having liver injury. Patients at low risk of liver injury, the low FIB-4, we shake their hands, say, congratulations, you're unlikely to have liver disease, and we'll recalculate this and every 2-3 years. In patients of an intermediate or a high value, something more than 1.3, we consider doing a secondary assessment. And that would include modalities like vibration-controlled transient elastography, MRE, and MRI-PDFF. These have, for the most part, replaced the liver biopsy. VCTE, vibration-controlled transient elastography, and MRE predict the likelihood of fibrosis. And you could actually estimate the severity of fibrosis. Transient elastography also gives a readout for fat deposition, so it could estimate the likelihood of having fat and the severity of fat. MRI-PDFF will estimate the likelihood of fatty deposition. So in my mind, I see a hierarchy for secondary assessments. On the top would be a liver biopsy, but as you know, we just can't do biopsies in everybody. It's a very invasive procedure. And it's been argued that it leads one to concerns about sampling error. You take 1/10,000th or 1/50,000th of the liver. On the contrary, MRE, MRI-PDFF, look at the whole liver. So people have argued it might be more accurate. So in my mind, the hierarchy is liver biopsy first. That has been the gold standard for years. And then the second in the hierarchy would be an MRE for looking for fibrosis and MRI-PDFF looking for fat. And in the third, I consider transient elastography. Routinely, what we do in our practice, if someone has an abnormal FIB-4, we'll do a transient elastography. In patients who were not able to do a transient elastography because of a large BMI or the space between the ribs being very narrow, or for whatever reason, we'll do an MRE and an MRI-PDFF. And based on those results, we're able to risk stratify someone and identify individuals who not only benefit from lifestyle modifications, which should be true for all patients with MASLD, but identify individuals who may benefit from pharmacological intervention. And as you know, we have 2 FDA-approved drugs approved today, Resmetirom and Ozempic for treatment of stage 2-3 fibrosis. So it's important to recognize that, again, patients with MASLD and MASH do not really occur in a vacuum. They occur in a setting of the metabolic syndrome. So it's important that when we assess individuals, we look for diabetes, we look for hyperlipidemia, we assess their blood pressure, and also assess their weight. And we should be as aggressive with their metabolic complications as we are in terms of reversing fibrosis. So, we work very closely with clinical nutritionists in our office, with dietitians, because there is an association with heart disease with cardiologists as well. So it does take a team approach, and it's important not to forget these metabolic issues, because they go hand in hand with MASLD and MASH. So I hope you enjoy this podcast, and for more information, please visit the website of CLDF. Thank you, everybody.